This is sort of where they survey the participants to what is the importance of each factor on your decision to give antipyretics or to treat a fever on a score from 1 to 5, with 1 representing non-important at all and 5 representing very important. And you can see that there are some variations between how nurses, pediatricians, and family practice physicians sort of rank the important reasons to treat a fever. And you can also see that the attitude towards a febrile child differed among professional groups. Most nurses agreed that a child with fever must be treated regardless of his or her general appearance and symptoms, but most doctors disagreed, namely about 62% of family doctors and 64% of pediatricians. Whereas most nurses also thought that a child should be woken up to take antipyretics. And I will say anecdotally, most parents feel the same way. But on the other hand, less than half of family physicians and even less than that of pediatricians believe one should wake a child just to treat the fever. Although it's nice to see, though, that most people did agree that the irritability and discomfort associated with fever was an important reason to treat it. But what does the evidence actually show? Should we be afraid as we are? So it's important as healthcare professionals to know how to calm parental fears. Again, to remind them that fever is a symptom of a disease, not a disease in itself. We keep saying we need to control the fever, we need to treat the fever. No, we need to identify and treat the thing that is causing the fever. The fever itself is not the illness. It's also, again, important to differentiate this from hyperthermia. So when a parent hears about a child who was left in a car and had a temperature of 106 and then had a seizure and brain damage, that is different from a child who has a fever related to an infection. And in general, a neurologically intact, healthy child will not mount an infectious fever high enough to cause brain damage. In other words, left to its own devices, your brain is not going to raise its thermoregulatory set point high enough to kill you. So one of the biggest fears that we've seen related to fever, and these are febrile seizures. So febrile seizures are actually very common. About 3 to 5% of children will have them, generally between the ages of 6 months to 6 years. If you have one febrile seizure, there's a decent chance you're going to have another, and with a recurrence rate of about 20 to 30%. Almost all of the time, it's just caused by a virus. And some viral infections seem to cause seizures more often than others, and some kids seem to get them and some kids don't. And as scary as they look, because they are terrifying to see a child seizing, there is actually no adverse long-term consequences in otherwise healthy children if they have a simple febrile seizure, which is something really important to tell the parents, because that is really what they are worried about. Another common myth related to febrile seizures is that if you just give them enough motion and Tylenol, they won't have one. And so you'll see parents who've had a child who had a febrile seizure, the next time that kid has a fever, they buy all of the Tylenol in the pharmacy. But that's actually not true. Contrary to popular belief, it's not the fever itself or even the height of the fever or the rate of rise that causes the seizure. The fever and the seizure are correlated, but they're not causative. Whatever infection and inflammatory response is causing the fever is also causing the seizure. So the fever, though, is not causing the seizure. And sort of a way to think about it is, it's raining, so I'm going to bring my coat and my umbrella. The umbrella isn't causing the coat. They are just correlated with each other, but both being caused by the fact that it's raining outside. So as a result, giving antipyretics doesn't actually reduce the risk of a febrile seizure. So this was a study where they randomized a group of 231 children who had their first time febrile seizure to the next time they had a fever to get either round-the-clock antipyretics, I think they mainly used diclofenac, or a placebo for every temperature they ever had for the next 2 years. And they found there was actually no significant difference in the rate of seizure recurrence between the group that got diclofenac for every fever or the placebo group. So preventing the fever doesn't actually prevent the seizure. So another myth that may actually be true is about the height of the fever. So hyperpyrexia, or a temperature more than 106, may actually be correlated with a serious bacterial infection. There have been a lot of studies with conflicting results, though. And in all of those studies, there's no single symptom or screening laboratory value that's going to tell you that this fever of 106 is due to meningitis, or this fever of 106, and not this fever of 106 is due to the flu or rhinovirus. But what every study did note is that the kids who had a high fever that was being caused by a serious bacterial infection looked bad. They looked ill, they looked toxic. There was no way the treating physician was just going to send that kid home and miss that and not work that up and miss that infection. So that should be very reassuring to those in the audience who treat children and are worried about missing an infection in a high fever, that when the height, even though the height of the fever may correlate with infection, there will be other signals that will tell you that as well. So children can have a fever as high as 106 for a simple viral infection, but if it's not just a simple viral infection, they will have other symptoms or an ill appearance that will let you know that. So if fever is our friend and not really damaging, why do we treat it? Well, one, kids with the fever are miserable. As pediatricians and as parents, we generally don't like to see children miserable, so make them feel better by giving them an antipyretic. The other risk with the fever is that it's true because of the hypermetabolic rate, there's increased fluid losses, but also children who are miserable don't eat and they don't drink. So you're at increased risk of dehydration, which is another reason to treat the fever. Additionally, as a physician, it's very hard to assess a child who has a fever. One, children always look sicker when they are febrile than when they are not. So you may not get an accurate view of what's really going on while they're febrile. They also are miserable and will not let you examine them. So it's always helpful to give an antipyretic first, wait till it kicks in, and then go and examine the child. So what's the bottom line for fever phobia? The bottom line is we need to treat the child, not just the number on the thermometer. So let's talk about antiphoresis. How do you get rid of a fever? So there are a lot of traditions, homeopathic remedies, wives' tales, some of which are more accurate than others. This I just found, just a quick Google to have found me a homeopathic website with different ways to get rid of a fever. Some of these aren't actually that wrong. Fever can cause dehydration, so feeding the baby and giving them more fluids, not a bad idea. Dressing your infant comfortably is also a good idea. A lot of people sort of worry that, oh, the kid has a fever, don't give them a blanket, undress them. That's just mean. Let them, they can be dressed warmly, it'll be fine. But you don't want to overdress them either. Now, there was a thought that sponging or bathing a child in tepid water would help reduce the temperature, but that actually only causes a marginal temperature reduction. It's really uncomfortable for the kid and it causes shivering, which might actually make the temperature go up. Additionally, using cold water or rubbing alcohol on the baby to try to reduce the fever won't really work that well, because if you remember, when you have a fever, you have peripheral vasoconstriction. So you're not really going to lose that much heat by rubbing cold water on the skin. Additionally, if you use rubbing alcohol, you do run the risk of dermal absorption, which has some toxicity to it. Now, the way most of us get rid of a fever is with some tried and true Motrin and Tylenol. Now, one common myth is that if a fever doesn't resolve with Motrin or Tylenol, it must be a really severe infection. It's not actually true. Again, the fever is not really going to go away until the thing causing the fever goes away too. The way, as mentioned, the way acetaminophen and NSAIDs work, by resetting your thermoregulatory set point back to normal by blocking the prostaglandin and cytokine response to the infection. Now, there actually is some evidence that they work better in combination, which is why a lot of times you'll hear alternate Motrin and Tylenol. It actually does work better, but there is a risk here of some administration and dosing errors. So if you are going to advise families to do that, I strongly recommend having them write out a schedule, 9 a.m. Tylenol, 12 p.m. Motrin, and have them check off as they go so that they don't overdose accidentally. So now I'm going to talk a little bit about fever by age. So I am going to say that these slides are generally geared mostly towards trainees or just non-pediatricians. But they're also generally pre-2020. So just in your mind, add the word COVID to every slide. So let's talk first about neonates. So neonates, or fever in a baby, for those of you who might just be starting your pediatric residencies, we tend to call these fibs in certain institutions, or fiblets. So if you're wondering what they're talking about on rounds, that's what they mean. So generally, we're looking at a fever in a baby is considered a rectal temperature greater than or equal to 38 degrees Celsius, so that's 100.4 Fahrenheit, without a localizing source and exam. If there's a localizing source and exam, your workup kind of goes in a different direction based on that source. And it doesn't matter if they have a fever at home, in the doctor's office, in the ER, wherever the fever is, we count it. And the reason we worry about fever in newborns is that they don't actually localize or manifest obvious signs of illness. So sometimes fever can be the only sign of an underlying illness in a child, in a newborn. So why are we so worried about fever in newborns? So newborns do not have a fully developed immune system, and before about 1 month of age, the blood-brain barrier is still open, which leaves a risk for spreading of infection to the central nervous system. And the incidence of a serious bacterial infection, or an SBI, in well-appearing infants, if they are less than 3 months old, is about 5 to 15%, and that number goes up to 20% in the first month of life. And what do I mean by a serious bacterial infection? So generally, we're most worried about meningitis and bacteremia or UTI. You could also see pneumonia, bacterial enteritis, or some skin or soft tissue infections, and then also worried about bone and joint infections. When again, a baby can't say, my hip hurts. But the question then is, does every febrile newborn need a full sepsis workup and admission and antibiotics? So the rates of invasive bacterial infection have decreased significantly since we started vaccinating and have reduced the overall population prevalence of strep pneumo and Haemophilus influenza type B. Additionally, doing that whole workup, admitting the patient, giving them antibiotics, it's not exactly a benign intervention. There have been cases of newborn babies developing urethral strictures after being cathed for urine, or significant damage around the spinal cord with hematomas and abscesses after LPs, or even just putting a simple peripheral IV as the risk of infiltration. Again, if you have a newborn who doesn't actually have a serious infection, now you're admitting them to the hospital and they could catch one. Again, and also with antibiotics, there's always the risk of allergic reactions or diarrhea, which a newborn doesn't really tolerate very well. So is there a way to kind of risk stratify these febrile infants to limit testing and treating just to those who really need it? So in the 1980s and early 90s, there were several research groups that looked into this, the most famous of which are Rochester, Philadelphia, and Boston. They're called their respective criteria. They all use slightly different values and slightly different protocols, but at the end of the day, it was basically looking for if the well-appearing febrile infant had a normal white cell count, a normal urine, plus or minus a normal CSF, they were low risk for bacterial infection and may not need a full sepsis workup or IV antibiotics. And most institutions have adopted some form of one of these protocols. There have also been some more recent updates. So the lab score sort of is very similar to the lab score, instead of using the white cell count, CSF, and urine, actually just look at procalcitonin, your CRP, and the results of the urine dip. And just those three values can predict the risk for a serious bacterial infection. The step-by-step algorithm is very similar to the Rochester, Boston, and Philadelphia criteria, but takes a more stepwise approach before getting each test, and it adds procalcitonin to the high-risk criteria. And instead of looking at just the full white blood cell count, it looks at the absolute neutrophil count. Now, more recently, in 2019, the Pediatric Emergency Care and Applied Research Network developed a prediction rule for low risk of serial bacterial infection in infants ages 0 to 60 days, where if those babies had a negative UA, a normal ANC, and a normal procalcitonin, they were also at lower risk of SBI and did not require a spinal tap and did not require admission for IV antibiotics. Most institutions have not adopted this for less than 1 month old, but the field probably is moving that way. And there are still some lingering questions. What do we do with a neonate who has a clear upper respiratory infection or bronchiolitis? Research does show that they have a lower risk of a co-infection with bacteremia or meningitis, but there is still about a 7 to 10% risk of a co-infection with a UTI. And another question is, since we're worried about meningitis in the newborn period, should we be worried about HSV meningitis in every newborn, especially when there's no maternal history of infection? And a 2020 update, if the newborn has COVID, do we need to look for anything else? So once you've decided that your patient likely does have a serious bacterial infection or is at risk of one, and you want to give antibiotics, which one should you give? So you want to make sure you're always treating the most common pathogens. For those in the audience who will soon be taking boards or a shelf exam or a step 1, 2, or 3, you always want to treat, the answer is going to be group E strep. So GBS, and then E. coli, strep pneumo, Staph aureus, H. flu, could still be H. flu type B in a newborn. and Enterococcus. And in the first month of life, you have to worry about listeria and various STDs that can be caught in the birth canal. The usual regimens are a third generation cephalosporin or gentamicin, and sometimes with the addition of ampicillin or acyclovir. So when I was a resident, we used to use cefotaxime and ampicillin, but there's been a national shortage of cefotaxime for the past 3 years with no signs of it abating. So many places now use ceftazidime and ampicillin, or gentamicin and ampicillin for the less than 1 month old, plus minus acyclovir. And the reason we are adding ampicillin in this age group is to give you listeria coverage. For the 1 to 2 months of age, usually just treat with ceftriaxone, with the caveat being that if the urine is positive, you may want to add ampicillin for better enterococcus coverage. So in summary, febrile baby, what should we do? Give them Tylenol because they are miserable, even though they can't tell you so. Get your thorough history exam. You still need to do that with every patient, even the tiniest ones, because that might help you look out for things you might otherwise miss. Especially ask about the prenatal history and mom's GBS and HSV status. And just make sure, in addition to worrying about what's causing the fever, you need to just see how well the child is doing overall. Are they feeding? Are they peeing? Do they need fluids? If they're less than 28 days, most institutions, despite the new PCARN guidelines, still do everything. Blood, urine, spinal tap, antibiotics, maybe acyclovir, and admit pending cultures. 28 to 56 days, usually we'll just start with blood and urine. If there's signs of bronchiolitis, we may only check urine. And if those are abnormal, then we do the rest of the workup. And if they're normal, we send the kid home. Most institutions do not do a significant workup beyond 2 months of age. And then other studies might be done if clinically relevant based on the exam and the history, such as testing for flu, getting a chest x-ray, and since 2020, stopping for COVID. So the next age group to talk about is infants and toddlers. So as pediatricians, we actually do something really mean to parents. We tell them when they have a baby, congratulations, you have a baby. If they ever have a fever, go to the ER, because fever in babies is really bad. And then the child hits 2 months and we say, okay, now stop being afraid of a fever. It's a little hard to do that. So febrile illness is actually the most common for older infants and toddlers between the ages of 3 to 36 months. We actually expect this age group, whether they go to daycare or not, to get 10 to 15 viral infections every year as they build up their immune system. So trying to explain to a parent who says, my kid is always sick. Well, yes, your kid is 1 year old. We expect them to be always sick and it's going to be okay. This is how they build their immune system. Now, even this, not really worrying so much about toddlers with fever, is somewhat new-ish. Because in the pre-vaccine era, we did work up febrile toddlers because of concerns for occult bacteremia. Now, before the pneumococcal and Hib vaccines, the rate of occult bacteremia in febrile toddlers was about 3%. After vaccines, it's less than 1% because vaccines work. So now that we have vaccines, what should we do? So one of the bacterial infections we do still worry about in the older infants mostly is urinary tract infections, with an overall prevalence of about 5%. And the rate is much higher among girls than among uncircumcised boys than among circumcised boys. And it's actually higher among Caucasians than among other minorities. And the AAP back in 2011 published guidelines to help decide who needs a urine cath, and which basically will depend on their race, their age, and how long and how high the fever was, and whether there's another source of infection. In general, they don't always view a upper respiratory infection because of the rate of co-infection with UTI as getting you out of a urine cath. Notably, usually when the probability is more than 1%, we tend to check. And you'll note that our probability of UTI exceeds 1% in an uncircumcised baby boy, even with no other risk factors. So an uncircumcised 3 months old coming with a fever is almost always going to get urine checked. Girls and circumcised boys, it will sort of depend on how long the fever is. And you can follow these guidelines. And to diagnose the urinary tract infection, it requires a positive urinalysis with either nitritis, leukocyte esterase, or pyuria, or having more than 50,000 colony-forming units of a pathogen in a catheterized specimen. You could have less in a suprapubic tap, but very few practitioners still do those. So then the other concern, so UTI, occult bacteremia, well, there's also occult pneumonia. So about 5 to 6% of children with fever in a normal exam will still have a positive x-ray. Notably though, most pneumonias in this age group are still going to be viral. But you should consider an x-ray for a temperature more than 39 degrees Celsius or an elevated white blood cell count. The risk of this being a pneumonia actually increases with the duration of the fever. Additionally, tachypnea can be a very subtle sign of pneumonia. So if you have a child who's tachypnic, even if their lungs are clear, you should consider a chest x-ray. Although this risk is actually probably getting better now that we have vaccines and we vaccinate for the most common causes of pneumonia. So you can sometimes limit your chest x-ray, you can limit the role of your chest x-ray in the absence of cough or respiratory symptoms. And as with most things above the diaphragm, if you do have a bacterial pneumonia, the treatment remains high dose amoxicillin. So now we can move on to the school age group. So this is a group where it's actually a little bit easier to evaluate because they can tell you what hurts. Most of their fevers and infections are still benign and self-limiting, and the management can sort of be guided based on their history and the exam. You always want to rule out things that are life-threatening, but usually the exam and the history can tell you what to look for and what's going on. So again, you want to get a very careful history. What are their symptoms? What are their exposures, comorbidity? Anyone in the house have COVID? And then what do they look like on exam? Do you see signs of meningitis? Are they coughing? Do they have an ear infection? Is their throat red with a rip-roaring exudate? And that sort of gives you a stepwise approach to treatment and management. Now, adolescents are also very similar because they can also localize infection, and you can also guide there by history and exam, but there are some special things to think about in this age group. They do sometimes live in congregate settings like camps and dormitories, where certain things that like to spread in crowded areas can affect them. So you can see a rapid spread of meningitis in a dorm. There is also a risk of hepatitis A, mono, and other infections. And while I know this is a JOWMA talk, you do still often have to be worried about sexual activity, and fever could be caused by an STD. Most teens actually are very forthcoming, but not always. And teens might also have bad habits. And here's where it's important to really differentiate fever versus hyperthermia. Is their temperature 103 because they're sick or because they took something that makes you hyperparexic? Additionally, you want to worry about things like heat stroke. Is your football player who's been running around and practicing in the middle of August without drinking anything and now comes in with a temperature of 104? That's probably not an infection. And again, for the past year, we've also had to worry about COVID exposure, and you should always keep the multisystem inflammatory syndrome in children that can happen after COVID in the back of your mind when you see a child with a fever and any sort of hint or history of a recent COVID infection. So now there are some special populations. So these are the cases where you actually should have fever phobia, where fever is not your friend. So again, anyone who has an immature or compromised immune system. So those are our fiblets or our fever in babies. Children with sickle cell disease because of their functional or actual asplenia at higher risk of infection with encapsulated bacteria. Patients who are neutropenic, they're either actually neutropenic because they're getting chemo, or even an oncology patient who's not neutropenic right now, if they're still being treated, the neutrophils they do have are likely not functional or not normally functional, so they're still at high risk. Short gut syndrome is a big one. The combination of GI bacterial translocation in this population with central lines and TPN gives them a 50% positive blood culture rate when they come in with a fever. If your patient is HIV positive, be sure to look for fungal infections. If they have an autoimmune or immune compromising illness, so these are your renal patients, your rheumatology patients, and your diabetics, they're also at increased risk. Or patients who are taking immunosuppressant medications, either to treat the illnesses above or post-transplant. And then again, some congenital immunodeficiency syndrome like SCID or DeGeorge also put them at high risk. Additionally, you should worry about patients who have a nidus for infection. So either central lines or hardware. Central lines put you at increased risk of bacteremia through the line, or even a thrombus around the line that then becomes infected. Hardware is also a big one. VP shunt can develop an infection at either end. So if you have a child with VP shunt who comes in with a fever, most practitioners know we need to image the brain, but you also want to think about getting an ultrasound of the abdomen to look for a peritoneal abscess. The ultrasound image you see here is an abscess around the peritoneal end of a VP shunt. Also, or anyone with orthopedic plates or screws, put them at risk of osteomyelitis. And with cochlear implants, a child who has otitis and a cochlear implant needs an LP. to rule out meningitis, just because that hardware provides the perfect conduit for CNS extension of the infection, specifically with mostly with strep pneumo and H flu. And again, a vagal nerve stimulator or a baclofen pump are also hardware and can become infected. So I'm going to spend a little bit of time about fever of unknown origin. So the definition of an FUO is daily or near daily fever greater than 101.3 for at least 7 to 9 days. And most of the time, these kids have been to the doctor a dozen times and we can't figure out what it's coming from. But it is important to differentiate an FUO from just a bunch of other illnesses in a row. So you really have to ask the parent. So did he have a fever Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, and Saturday? And all the times they'll say, no, he had a fever and a runny nose on Sunday and Monday. That got better. But then on Friday, he had a fever again and a sore throat. That is not a fever of unknown origin. That is a kid who had the misfortune of having a viral URI, getting better, and then getting strep throat at the end of the week. So it's important to sort of differentiate that. Now, once you have identified that this is a fever of unknown origin, you can take a stepwise approach to try to identify what's causing it. And this is really where your risk factors, your history and exam come into play. In general, about half of these FUOs still turn out to be infectious, usually respiratory. Sometimes you'll have some of the more rare things you want to look for based on their risk factors, such as HIV, TB, and sometimes exotic or emerging infections. About 10 to 20% of these fevers end up being something rheumatologic, such as JIA or lupus. Unfortunately, 8% do end up being a sign of a malignancy, and a decent 1/10 to 1/5 simply remain unknown, go away, and we never figure out why they were there. As the duration increases, the infectious source is actually still becomes less likely. So a fever for a week or so, most likely an infection. A fever for 2 weeks, most likely a zebra. So the take-home points are most fevers are benign. Your history and your physical are still key. You should avoid fever phobia unless your patient is immunocompromised or has hardware. Prolonged fevers are often still infections, but look out for zebras. And most importantly, treat the child, not the temperature. Thank you very much. And these are my references, and I think we have some time for questions.
Thank you so much. This was just as helpful now as I remember the last time I heard a fever lecture, and you know, so many important misconceptions and important pearls, both for, you know, parents and trainees, etc. So thank you so much for that. I have a question for you about the fiblet workup and the fact that it seems like maybe the data is pointing in one direction, but from the sounds of it, it's going to take a little bit more time until that might get implemented into clinical practice. And I'm wondering, is it just that you've all sort of been burned where you've had a kid who had a URI going around the house and they have a URI and then, you know, their LP like suddenly shows something terrible that you weren't expecting? Is that what it is?
I don't think it's so much that people have been burned because, you know, fortunately, as you know, with the vaccine era, we get burned less and less often, which is really nice. I think it's more just in general, it takes some time for medical standards and dogma to evolve and change. And a lot of the new studies, especially the PCARN rule, came out in 2019. A lot of things happened since then, as we all know. And so I think there just hasn't really been the opportunity for a lot of the information to get disseminated as widely as it needs to be, and for standards and protocols to be updated accordingly. But I think the field in general is moving in that direction. And I am looking forward to the day where we do we already actually do much fewer spinal taps than we did before. And I'm looking forward to the day where we do almost none.
Very reassuring to know that. Thank you. We have one question from Dr. Minkin about rectal temperature being closer to 99.6.
Oh, so I believe she is referring to, there have been some new studies recently that show that what we call normal might not really be normal temperature, which actually our normal temperature might actually be a little higher than 98.6. And this might actually be true because the original view of 98.6 as the normal body temperature was, and I actually do have a slide that I had cut out, but was actually developed by a physician named Carl Wunderlich in 1868, who took this foot-long axillary thermometer, and fortunately for his subjects, he felt that axillary temperatures were sufficient, and took 1 million measurements on 25,000 adults, took the average in the range, and said, oh, normal temperature is 98.6. And that's sort of just been the dogma since then. And it may be time to readdress that. And then there is also thought that a rectal temperature of a 99.6 may be more indicative, could be considered possibly a fever, although usually we still use 100.4 as our cutoff for the workup, at least in the emergency room. But in
Okay.
general, your rectal temperature is much more consistent with your actual core temperature, and will usually be a little bit higher than your axillary temporal or tympanic temperature, and much higher than the contactless thermometer.
Yeah, thank you for clarifying. So just another thought about COVID, because I think this is something we're all wondering about. And I'm approaching this not as a pediatrician, more as a layperson and in the community. I just had a friend reach out to say, my kid keeps having strep and he's had it 3 times, just this winter, but now he has strep again and they're making him go for a COVID test, even though it's like his typical presentation of, fever, sore throat, whatever. So can you just address what your thoughts are on testing and when you would incorporate that into the algorithm?
So a lot of that's going to depend on the prevalence of a COVID. When the prevalence of any illness is low and you get a test for it, the positive predictive value of that test gets lower because the overall prevalence is lower. But when the prevalence is high, the positive predictive value is higher. Now, in a situation where COVID prevalence is low, the odds of having both strep and COVID are going to be low. Today, where COVID prevalence is anything but low, unfortunately, the odds of having strep and COVID get a little bit higher. And we have seen a lot of cases where, even in the ER, where a child comes to the ER for a non-COVID related complaint and is incidentally found to be COVID positive on their pre-admission testing. So from a public health perspective, at a time when prevalence is high and where you're trying to prevent spread of infection and may actually want to catch even, asymptomatic COVID. So is the sore throat strep or is the sore throat COVID? But sore throat could be strep, but you could have asymptomatic COVID on top of it. You probably still do want to test. Of course, it also depends on what your public health concerns are there. Would I necessarily want that child back in school without a negative COVID test, because even with a positive strep? I think that's sort of really going to depend on the individual situation. What are the risk factors for there being COVID? Has there been any COVID exposure? Is it really just a sore throat and fever? And do I see an exudate on the throat or not? Because there are also plenty of children who are colonized with strep, and you'll have a positive rapid, but it's not an active strep infection. So those are all decisions that will have to be made almost on an individual basis by the treating physician, with a lot of different things to balance between the needs of the individual and also the public health perspective during a pandemic.
Yes, thank you. It's certainly an evolving situation. I remember, when it came to the SARS epidemic that was going on in Canada, I was in my first year of medical school, and one of my mentors reached out to me. She's like, everything you're learning about now is kind of teaching you how to think about medicine. But I guarantee you, when I was in medical school, they didn't teach us about SARS because we didn't know about SARS. And I guarantee you there's going to be something else that comes up when you're in practice that they didn't teach you about in medical school, but you're learning principles and you're learning how to apply those principles in different situations. And, I see now how prescient that was and how right she was, because COVID is such an evolving situation, and it takes all of your expertise and your skills as a practitioner and all of the knowledge that you've built up, and then test it in an unusual way that you've sort of never anticipated when you were training.
Yeah. It's sort of interesting to be learning medicine as we're practicing it. And I am just always wondering, so 20 years from now, when I'm an older attending and I've got new medical students and who were born after COVID or, came of age after COVID and they're learning about COVID and how much they're going to look back and be like, you guys did that? What were you thinking? And a lot of it's going to be, well, we were building the plane as we were flying it. And we were learning based on starting with first principles and learning about this new illness. And it's amazing what we've actually learned in just a year treating it. And we still have a lot to go, but we definitely know a lot more than we did last March.
Have you seen that evolve in just in your own personal ER in ways that you think you could share? Because, not exactly apropos to your talk, but, I think you're in this situation where you're the frontline physician caring for a lot of, children, infants who come in. This doesn't really seem to be much of a children's or infants disease, but I'm sure it's affected a lot of what you do day to day.
I mean, so we've definitely, it does, well, overall, children and infants certainly do not get as sick as adults do. They can still get sick from COVID, especially the newborns and infants and the older teenagers who are pretty much biologically adults. But one of the things that we have seen is our knowledge evolve. So, earlier on in the pandemic, everyone thought of COVID as cough, fever, shortness of breath. But in the first couple of weeks, we learned that in kids, it's often actually more of a GI bug with vomiting and diarrhea. And it took, so then once we learned that, we're like, oh, those kids also have to be screened for COVID. Another thing that certainly evolved is the management of MISC, which was an entity that didn't exist since 6 months ago. And I remember like some of the having some of those earlier patients in the ER when we didn't even have a name for what they were presenting with. And our management of that has certainly evolved, as we originally thought it was just some sort of Kawasaki disease, but then we have since learned that it is actually its own entity that has some overlapping features of Kawasaki, but is a different illness. And while there is some overlap in the treatment, there are important differences. And we've gotten much better at identifying and having sort of protocols and included criteria for testing and treating as well with the various different treatment modalities that we were just not aware of when it first emerged. So that's definitely been new. But we have seen the management evolve in the same way that we've seen it evolve in adults.
Yeah, no, very interesting. I mean, again, we'll be writing the books in a few years,
Yeah.
Hopefully with all of this in our rearview mirror, well in our rearview mirror. Yeah, but I if anyone has questions, feel free to type them into the chat box and I'll keep you anonymous, I promise. I think one of the things you said that was really interesting, and I remember this again from a while ago, but it was good to hear it reiterated about febrile seizures. I think a lot of us are very, very afraid of, the ultimate bad sequela of fever in a kid. And, just to hear the reassurance that that's not necessarily something that you can prevent with antipyretics. And it's, in and of itself is not something to be quite as nervous about as maybe some of us are who, aren't doing this on a daily basis and haven't read the literature. So thank you for that reassurance.
And I would say even as an ER physician, it's still scary to see a kid seizing.
Yeah. Yeah, I'll never forget how, seeing an ambulance call for a little kid, and it was for a febrile seizure. And I was like, I don't know that any other parent would have reacted differently. It was like on a Yentef in an isolated place, where there was no local doctor. And, I was thinking to myself afterwards, like, I guess that's what you kind of got to do, but, it can be very scary. So thank you for the reassurance about that.
Thank you. And I would still want a child to bring their febrile seizure to the ER.
Yeah.
I still want to take a look at that kid, see if there's some obvious infection we could treat, and, give some reassurance and send them on their way.
Okay. So, and just back to the fiblet thing. So again, I had that call from a relative with a 3-week-old baby and URIs going around the family. and her baby had fever just like everybody else in the house did. What do you think is the likelihood that that baby's going to get an LP? Because that was her big fear when she called me. It was a few years ago, and I was like, you have to go. She's like, I know this kid has a respiratory infection like the rest of the family does, but I'm like, you have to go, and it's going to happen, and there's nothing to do. But again, it sounds like that's still probably going to happen.
Yeah, so today that likelihood is still pretty high at 3 weeks. At 5 weeks, that likelihood becomes very low. But I do think that will change as more of the evidence gets adopted and protocols get updated accordingly.
Okay, well, good to know, and we'll stay tuned to watch your field evolve, just as I like watching my field evolve. That's what keeps me interested in medicine. One more thing I'll tell anyone here who's not going to be a pediatric resident or who might be an early trainee. So I heard this lecture, and I remember one of the first days I was rounding as a sub-intern. I did a sub-internship in pediatrics because I just found Dr. Avner and everybody else at Montefiore to be, just so good at what they did, and I wanted to really learn from them. So I did my sub-internship, and the first morning I walked in, and they were going through the vitals of all the patients, and my patient had spiked. And I was like, oh, okay, fever is your friend. Great. So the kid spiked, he looks fine, no problem. But then, at some point the attending walked in a few hours later, and she's like, did you know that baby spiked last night? Like, nobody told me. It wasn't an infant, it was a few months older, but I was like, yeah, but fever is your friend. Fever is your friend, but if your patient spikes when you're the resident or the sub-intern or the medical student, you have to work it up. So that's coming from me as a non-pediatrics person, and that was my rookie mistake. So
again, and we do that sort of is how we, in one way, perpetuate the fever phobia, because it becomes very hard for us to separate your child who's in the hospital for something is not your well-appearing, low-risk kid you don't need to worry about, but just cognitively then being like, but this other kid I really don't need to worry about. As hard as that is for us, it's even harder for families.
Yeah. Good point. It all depends on the context. So, I'm sorry, one more question. I think we have a couple minutes. If a 3-week-old has a fever and tests positive for COVID, how much workup do you need to do in that 3-week-old who has a positive COVID test?
This is the $1 million question of, in, I guess, Fiblets for 2020. At this point, in general, we are still going to work that kid up at 3 weeks, largely because our protocols just haven't necessarily caught up, and we actually don't know what the rate of co-infection with something else is with COVID. At the very least, I definitely want to get a urine, just because we know that there's a high rate of co-infection of UTI with other viral illnesses. So I don't have a reason to suspect that to be different with COVID. Although I could be wrong, because we've been wrong about a lot of things with COVID. But given the lack of evidence one way or the other, I do think a 3-week-old with a fever who is COVID positive is still going to get a workup.
Okay, there you have it. All right, if there are no further questions, thank you so much, Dr. Nemetski. And thanks to everyone else who helped out with this webinar. Thank you so much for everyone who called in. And I found this to be incredibly informative and helpful to me as a parent, and hopefully everybody else did too. So thank you so much for your time, and have a very good night.
And thank you so much for having me. And I'm looking forward to seeing the rest of the Grand Round series.
Yeah, stay tuned. All right, have a good night.
Night.